intensive blood pressure. This is going to be presented by Dr. Pareek. Please. We have only one mic, so please, when you ask a question, come here, because nobody can hear anything otherwise. Please.
Good afternoon, everyone. Thank you, Chair, for the introduction. It's a pleasure to be here and to present our findings from this paper entitled the 2018 ESC ESH guideline-recommended age categories in intensive blood pressure management in high-risk adults, insights from the systolic blood pressure intervention trial, or SPRINT as most of you know it. So the 2018 ESC ESH guidelines recommend differential management according to patient's age. So there are different thresholds for patients who are less than 65, 65 to 79, and equal to or above 80 years of age. But it's unclear whether intensive blood pressure lowering is well tolerated and modifies risk uniformly across this entire age spectrum. So the purpose of our study was to assess whether age modified the efficacy and safety of intensive versus standard blood pressure lowering. We used data from the SPRINT trial, in which 9,361 individuals at high cardiovascular risk but without diabetes were randomized to either intensive or standard antihypertensive treatment. Of note, individuals with a 1-minute standing systolic blood pressure below 110 were excluded. The primary efficacy endpoint was a composite of myocardial infarction, other acute coronary syndromes, stroke, acute decompensated heart failure, or death from cardiovascular causes. And the primary safety endpoint was a composite of a variety of serious adverse events. We used Cox proportional hazard progression and restricted cubic splines to examine the relationships between age and study endpoints, as well as the effects of intensive versus standard blood pressure lowering across the age spectrum. This figure shows the age distribution in SPRINT, and as you can see, 41%, 47%, and 12% of individuals belong to each of the 3 age categories that I mentioned. In comprehensively adjusted multivariable models, age was linearly associated with the risk of stroke and non-linearly with the risk of all other tested endpoints. But the efficacy of intensive blood pressure lowering was not modified by age, whether we tested it continuously or categorically. In fact, if you look at the absolute risk reduction, it was highest for individuals who are equal to or above 80 years of age, corresponding to the lowest number needed to treat. And likewise, age did not modify the effect of intensive blood pressure lowering on the risk of serious adverse events. Again, the absolute risk increase in the number of serious adverse events was not greatest among the individuals who were equal to or above 80 years of age. In fact, the opposite seemed to be the case. So in conclusion, the benefits and risks of intensive blood pressure lowering did not differ according to the age categories proposed by the ESC and ESH guidelines for hypertension. And we suggest that decision-making surrounding more intensive blood pressure targets should move beyond age alone. Thank you for listening.